Hi everyone, welcome back for Chapter 16, Breastfeeding. As we discussed previously, breastfeeding is recommended through the first 6 months of life, and the reasons for that is that it is considered the optimal choice of nutrition for newborns and infants. Breast milk gives baby the nutrition essential for optimal growth and development. But on top of that, breast milk contains immune substances that help the baby fight infection. Breastfeeding also serves as a great bonding time for parents and babies to develop better physical, psychological, and emotional benefits throughout lifetime. After 6 months of breastfeeding, it is recommended to continue breastfeeding with introduction of foods. Healthy People 2020 has numerous goals on the promotion of breastfeeding, and I'm not going to read those to you, but you can review those. In the early 90s, the WHO developed a baby-friendly hospital initiative, and that was to offer support to moms and babies right after the baby was born. So these hospitals in this hospital initiative have a written breastfeeding policy and staff training. There's lots of education on the benefits and management of breastfeeding. They work to initiate first nursing 30 minutes after birth. They have lactation consultants available to help in education. They have rooming in practices. They don't offer pacifiers. And then they have breastfeeding support groups. So we're going to go over just a little bit of the benefits of breastfeeding. Breast milk is specific to that baby with vitamins, minerals, macro and micronutrients for the little one, ideal to support growth of the baby. And it also changes as the baby grows and changes. Lots of short and long-term benefits, lower risk of GI issues, helps decrease the incidence of necrotizing enterocolitis, ear infections, respiratory infections, asthma, skin issues, diabetes, SIDS, and leukemia. Other benefits include benefits to mom, returning to a pre-pregnancy state, strong bonds, decreasing the risk of ovarian and breast cancer, and then decreasing metabolic syndrome, type 2 diabetes, and postpartum depression. There's several economic benefits, being plentiful, decreased medical cost. Some contraindications we have listed in the book, page 199, and although they are rare, there are occasions. The first one being galactosemia in the little one, and that's an inherited disorder where there's processing issues with energy from sugar. If mom has a T-cell virus, tuberculosis, if mom has cancer undergoing treatment, HIV, if there's herpetic lesions on mom's nipples, use of drugs, and then some more specific considerations if either mom or baby has an illness, milk supply issues, breast surgery issues for mom. And if these contraindications are known, then there may be the use for donor milk to be used. So mom and baby is still receiving breast milk. So that initial milk production is called colostrum, and it begins around 16 weeks of gestation. We know that it is has fewer calories and has lower fat than mature milk later on. But this colostrum is rich in immunoglobulins and antibodies that will help protect the baby. It's especially high in immunoglobulin A, and this one is very important because it coats the gut with protection against bacteria and decreases overall gut inflammation. There's transitional milk that presents between 32 and 96 hours after birth, and then mature milk is typically in place by the second week after birth. Mature milk is known to be 90% water, has good fat that is variable, is known to have high protein, 60 to 70% whey, and 30 to 40% casein, known to have good carbs in its lactose, and has plenty of the vitamins and minerals, but can be low in vitamin D and iron. The current recommendation for vitamin D from the AAP, though, is a 400 international unit a day beginning shortly after birth for all infants, including those that are exclusively breastfed. So just a little bit on the anatomy and physiology of the breast. A process termed mammogenesis begins in the final stages of pregnancy. And this is where the mammary gland begins to grow and develop, and it supports breast milk production. By about 20 weeks, the breast is capable of milk production. The actual production of breast milk is triggered by the fall in progesterone concentrations after the birth of the baby and the delivery of the placenta. The suckling action by the baby helps establish and maintain lactation, and it's definitely on a demand and supply process. Oxytocin helps with the letdown reflex, and if you look on page 202, there is a diagram of the neuroendocrine loop for oxytocin, just to give a visual on that. We all know that the size and the shape and the position of the breast and the nipples may vary, but there's very few conditions that are going to keep mom from nursing her baby. We will talk about some more normal findings and maybe some abnormal findings. So there's many factors that go into the success of breastfeeding. And this includes mom's knowledge of breastfeeding, understanding techniques for getting off to a good start, and identifying any contraindications for breastfeeding. It's important to have a nipple evaluation completed, and all pregnant women should be assessed regardless of what their past breastfeeding experiences have been. With mom, you're wanting to get a maternal history, you're wanting to know overall health, any previous experiences, any cultural expectations, medications, surgical interventions, especially to the breast, what their nutritional status is, the support that they have, more about their pregnancy and perinatal history, and then what went on during labor and delivery. The next part of this dyad is the infant's history, so overall health status, if there are any congenital conditions, how was delivery, were there any trauma or complications, has the baby been on any medications or currently on or exposed to any medications, have they had any procedures, circumcisions, Billy Lights, how have they done with the bottle cup, or if they've had any tube feedings, what was their gestational age, and what were the early responses to feeding attempts. Examination of mom's nipple, as we talked about, is it everted, flat, or inverted? Are there any surgical scars on the breast or thorax from previous surgeries? Any nipple bruising or bleeding? You also want to assess the oral motor skills of the baby. Make sure that the hard and soft palates are intact. Assess the frenulum. Do they have the ability to stick out their tongue? Because without that ability, then successful lactation is going to be difficult. There are numerous positions for breastfeeding, but the most important is that mom and baby are comfortable. It's important to have a face on at the nipple. If you're not familiar with various positions of breastfeeding, on page 204 and 205, there are some excellent pictures, and I think pictures are more descriptive than trying to explain. But baby can be on their side, not on their back, and needs to be supported in good alignment. Their top and bottom lips need to be flanged, and there's an example of that. On figure 16.4, the tongue needs to extend forward. There needs to be a quiet feeding. If there's clicks or pops, baby hasn't latched on well, and audible swallowing is a good indication that your milk is letting down and baby is getting breast milk. We're not going to go into positions in detail. As I said, look at those with pictures on page 204 and 205. Some other dynamics to talk about with breastfeeding is an early feeding. And as we talked about with the guidelines from hospital initiatives, as soon as possible after birth, and the goal is between 30 and 60 minutes after delivery. Early feedings, trying to be aware of the sleep alert cycles and trying to and then to have practice latching on and suckling. At discharge, it's important that You review positioning and latching on, review signs of progress and making sure that baby has adequate nutrition. We're going to go over some of those. Arrange for a daily follow-up for the first 2 to 3 days after birth. Have phone contact if places to reach out to, such as a lactation consultant if mom has any questions, and then giving breastfeeding resources. So the frequency of breastfeeding can be anywhere from 8 to 12 feedings per day after the first 24 hours, and these feedings can last anywhere from 20 to 45 minutes per feeding. If mom is not going to be able to be with the baby for more than 1 to 2 feedings, then pumping is recommended. Collection or storage of breast milk is important that mom is aware of. How to clean the pump, how to store small amounts, and then how to store breast milk in the refrigerator and then in the freezer as well. We have all heard the term growth spurts, and often mom feels like she's just gotten in the groove of breastfeeding well, and the first growth spurt occurs, and she may not be prepared for that. That's when the baby is hungry all the time because the baby's growth demands are greater than the breast milk supply at the time. So baby is wanting to eat more than they might typically have been previously. It's important to feed on demand at this time. That will also help with production of breast milk. Babies may cluster feed at this time. Many moms may stop breastfeeding by the age of 1, but there are some that choose to continue breastfeeding toddlers, and so that's your personal choice. There are continued benefits to the child, but it is recommended that any nursing be done after a meal, not on demand. If you are tandem feeding, meaning feeding a baby and a toddler, that you always feed the infant first. They recommend that toddlers, their dentists be aware that they are breastfeeding, and important to brush their teeth before bedtime but after nursing. So weaning is the decision to stop breastfeeding, and that's a very individual one. There's lots of factors that come into play: their beliefs, desires of the mom and the family members, the developmental readiness of the baby, nutritional replacements for breast milk, and environmental factors. So the goal of breastfeeding is to meet the nutritional needs of the baby, and part of that is infant weight gain. We know in the first few days of life that there can be expected weight loss, but after that period, you're expecting between a half to 1 ounce of weight gain per day. You're expecting to see baby back to birth weight by 3 to 4 weeks, looking for a doubling of weight by 5 to 6 months, and a tripling of birth weight by 1 year. Some characteristics of a healthy breastfed baby include being active and alert, appropriate developmentally, age appropriate, head and height circumference, good skin turgor, good color, showing well hydrated, the child being well hydrated, several wet diapers and stools per day. This is saying minimum of 6, and baby being content and satisfied after feedings. Other guidelines include urine output, 1 to 3 wet diapers in the first few days, from day 3 and 4, anywhere from 4 to 6, and after that anywhere from 6 to 8 wet diapers a day. Stool output is also indicative of how successful breastfeeding is going to be. Meconium is noted in the first 24 hours. By day 3, you should start seeing some transitional stools, and then you're probably going to note 2 to 3 stools per day, and some babies may stool with each feeding. So in this process, mom needs to stay as nutritiously sound as she can be while she's nursing. Minimum is recommended of 1,800 calories. Caloric intake needs to be about 300 calories more over the pre-pregnancy recommendation. Having a diet that's focused on fresh fruits and vegetables, whole grains, lean meats, good protein. Supplementation with prenatal vitamins for calcium, zinc, folate, magnesium, and B6. Water intake needs to be increased, estimated at about 3.5 liters per day. There doesn't need to be any exclusion of food unless it's known that it's causing issues with the baby. Alcohol needs to be limited, and minimize caffeine intake. It's important that the practitioner is knowledgeable of medications for breastfeeding moms. And in Nursing 547, there is the resource section. I encourage you to look there because, sorry, I apologize. My phone rang and I'm not for sure where we got with this, but I believe we talked about in Nursing 547 the resources section, and there's a book in there called Hale's Medication for Mother's Milk. So I encourage you to review that if you are someone that's going to be working with pregnant moms, with breastfeeding moms, to have a better understanding of what medications they can use. Also, on your drug apps on your phone, if you're using that as a resource, um, most times that they will have something there that is giving more information for pregnancy. Like in Hippocrates, they have a section that once you type in the drug's name, you can go to pregnancy and lactation, and then that will give more information on whether the medication can be used in pregnancy or lactation, and give some more guidance. But know the drugs that are normally safe for infants. Avoid long-term forms of medications, extended release. If you start a mom that's nursing on a new medication, they want to observe for any changes in the infant, such as feeding issues, fussiness. Avoid any drugs that can inhibit prolactin release. And here at the bottom is box 16.2, talks about drug references, one of them being Hale's Medications in Mother's Milk. Another one is a source from the U.S. National Library of Medicine. And then Pharmacotherapeutics for Advanced Nurse Practitioners by Wu has been recommended as a drug reference for this. So lots of resources out there. When moms are interested in returning to work, they may want to continue to breastfeed, so be supportive of that. Help them to have, encourage them to find access to a private space where they can pump. They're going to need to have breaks and lunch times where they can have up to 30 minutes to accomplish this. Make sure that they are looking for supportive colleagues and supervisors that will help them to be successful. So let's talk next about some common breastfeeding problems. When moms have flat or inverted nipples, this can cause some frustration with the baby. There can be inadequate nutrition. The breast is not able to release the milk, so therefore there can be engorgement. Some things that mom can do in the prenatal period is wear some breast shells in the 3rd trimester, and that's going to help those nipples to pull out some. And then postpartum wise, continue with the breast shields and then manipulation of the nipple to help keep it extended. This is definitely a time when a lactation consultant may be appropriate if there's continued issues. Most most nursing moms have commented on sore nipples. This can be caused by irritation or trauma related to improper latching on, positioning, inappropriate suction release. It can be caused by thrush or not allowing the nipples to dry out. They can be tender, bruised, they can be cracked or bleeding. As you're working this up, though, you need to consider several other differential diagnoses. In the beginning, it may be mild tenderness. The trauma could be coming from another cause. There could be mastitis or an abscess, milk plugs at the nipple pores. So educate your moms to be aware and assess if they're having any issues so that prevention can occur early. Often releasing some of the breast milk onto the nipple and allowing it to dry has very healing properties. Allowing the nipples to air dry is very beneficial. Using breast shields to prevent friction. Having the baby move back and forth from the breast for shorter intervals may help, and to start on the least sore side first when baby has the strongest. Another condition that can happen is severe engorgement, and is when the breasts are full and swollen with milk. The breast can be painful, hard, and swollen, warm to the touch. They can have a bruised or traumatic experience, a traumatic look to them, excuse me. Management of this is warm compresses before nursing. A hot shower can help have release of the milk. Gentle massage, manual expression of the milk before feeding to help soften the breast. With severe engorgement, it's important that mom nurse frequently and ensure a proper latch on, and not to go for long stretches in between feedings. And this may mean getting up in the middle of the night to feed or to pump to express. So mastitis is an infection of the breast and can happen anytime during lactation, and can be including in pregnancy, caused by Staph aureus. And some predisposing factors include stress and fatigue, cracked nipples, ill-fitting bras, not emptying the breast adequately, or a sudden weaning or a significant decrease in the number of feedings. In figure 1611 on page 211, there is a picture of mastitis, and you will see that it is noted, the breast is noted to be red and streaking along the duct. For the mom with mastitis, they may definitely have fatigue, breast tenderness, red, warm breast, flu-like symptoms. Management, as we talked about, emptying the breast and nursing frequently. Pain, analgesia for issues that they're having, antibiotics if needed, rest, warm showers, warm compresses, increased fluids, and then be sure to not abruptly wean because of the possibility of the mastitis turning into an abscess. The next thing we're going to talk about briefly is nipple confusion, or maybe known as nipple preference. And this can happen when the baby is accustomed to nursing from a bottle and is introduced back to the breast. You may notice ineffective sucking or refusing to take the breast. Some ways to help manage this is to avoid a rubber nipple for the first 4 to 6 weeks. Try to retrain the baby and have them in a correct position. That will help with latching on and the baby not having to work as hard so that they can get that release of milk. And this may be a time when a lactation consultant is needed. With nipple confusion, you can have failure to thrive, increased in the belly, crying, prolonged feedings. Mom can have sore or cracked nipples, mastitis, and of course frustration. So it's important to, be working with mom regarding these concerns. So another condition that is common with breastfeeding is breast milk jaundice. And this is where there's an elevated serum indirect bili, and it peaks usually around the 7th to 10th day after delivery. And these are babies that are taking in appropriate amounts of breast milk with no other issues or concerns or signs of liver abnormality. The baby is healthy and thriving. They're gaining weight. They're voiding and stooling as needed. With these babies, though, you will check a serum bilirubin. You might need to do cultures if you're trying to rule out an infection. On your differential diagnosis, you need to rule out pathological jaundice, and its management is just to continue to breastfeed, making sure that baby continues to have appropriate stools and voiding, and offer mom reassurances. Another common problem in breastfeeding is thrush, and that is oral candidiasis in the infant's mouth or on the areola or the nipple of the mom. And if that has occurred in one or the other, both parties need to be treated. Another issue would be poor weight gain. And this is the baby that's having infrequent or inadequate feedings. Mom may not be having enough milk production. There could be an infection or an organic disease going on, or there could be a physical anomaly that's not allowing the baby to suck or swallow. In your assessment of the baby, you want to monitor for continued weight loss or the failure to gain weight back to the birth weight. The weight is below the third percentile. The baby could be lethargic, sleepy, inactive, or unresponsive. The baby is sleeping longer than 4 hours between feedings, and they may have poor skin turgor and dry mucous membranes, indicating that they're dehydrated. Poor weight gain may be due to a technique, not being able to latch on or suckle, too short a time at the breast, giving water between feedings, sleeping too long, having fewer feedings than 8 feedings in a 24-hour period. Maternal factors could include no initial response to cues, hectic schedule, recent illness, or being on oral contraceptives or other hormones. And our last slide, as we finish up poor weight gain, part of your differential diagnosis could be failure to thrive. It's important to get a complete history, talk about breastfeeding techniques, giving encouragement, instruction on ways that maybe mom and baby could manage breastfeeding, refer for any physical causes, be alert to extreme weight loss, and if necessary, admit the baby for calories and supplements if required. Poor weight gain can cause developmental delays, poor bonding, and severe dehydration. So I believe we're at the end of chapter 16, and thank you for your time. If you have any questions, just let me know.